Good morning, everyone. Welcoming you all to our Sunday CME. Today we have a very good speaker, our specialist radiologist, Dr. Raj Kumar Parmanand, who is speaking on the topic Radiological Imaging in Obstructive Jaundice. Going back to doctor's academic background, doctor has completed MD in radio diagnosis from the prestigious BJ Medical College, Ahmedabad. Sir was honored as the Fellow of Royal College of Radiologists in 2012. Sir has over 15 years of experience in radiology and has worked at different private hospitals in Gujarat before coming here. Sir has been working with Ahalia for the past 12 years, and special areas of interest are plain radiographs and MRI. Welcome you, sir, for presenting the CME. Thank you.
Thank you, ma'am. So today I am going to talk about the imaging in obstructive jaundice. The objectives of my talk are going to be brief introduction to the etiology of obstructive jaundice, then discuss the scope of various imaging modalities in evaluation of obstructive jaundice, and describe radiological features of common conditions which are presenting with the obstructive jaundice. So jaundice, as we all know, is a yellowish discoloration of the skin and sclera, which is caused by elevated levels of bilirubin in the blood. And it's not a disease per se, but it's a visible sign of underlying disease process. And typically seen when the level of bilirubin in the blood exceeds 2.5 to 3 milligram per deciliter. So basically, jaundice can be divided largely into two types: non-obstructive and obstructive causes. Non-obstructive are the pre-hepatic and hepatic, which affect the conjugation, and the obstructive is post-hepatic causes when the conjugated bilirubin is accumulated in the blood, so it's a conjugated hyperbilirubinemia. And imaging has a major role in detecting the obstructive causes. So common causes of obstructive jaundice, they can be divided like a benign, malignant, or they can be divided into mural, intraluminal, extrinsic. But I think the benign and malignant is an easier way to look into it. The most common causes are enumerated here. In the benign causes, the most common is the choleleucolithiasis. The other ones are the parasitic infestations, benign strictures that are mainly post-operative, post-inflammatory, and associated with primary sclerosing cholangitis. External compression of bile duct may be due to pancreatic conditions like chronic pancreatitis and special condition known Malaysia Syndrome, which is a complication of a gallstone, and some developmental malformations like choledochal cyst. The malignant causes, the most common malignant cause to present with obstructive is the carcinoma head of pancreas. Other ones are the cholangiocarcinoma, periampullary carcinoma, and metastasis in lymphoma, which usually due to the associated lymphadenopathy, there is external compression of the bile duct and secondary obstructive jaundice. The same thing is in a bit of graphic fashion. Now, before we move on to the role of imaging in obstructive jaundice, a brief anatomy of the biliary tract. Gallbladder drains to the cystic duct, and there are from the liver there are right and left hepatic ducts which drain the liver segments. The left one draining the segment 1 to 4 of the left lobe, and the right one draining the segment 5 to 8 of the right. They both join together to form a common hepatic duct, which joins with the cystic duct to form a common bile duct, and which then runs down and drains into the duodenum, the major duodenal papilla, through the ampulla of Vater. And this opening is a common shared with the main pancreatic duct. Some literature describes both the common hepatic and common bile duct as a common duct, but we will be using as a common hepatic duct proximal to the cystic duct and common bile duct distal to the cystic duct incision. So this is a segmental anatomy. Normally the most common anatomy is like there is a right anterior and posterior sectoral ducts which drains the anterior and posterior segments of the right lobe and drain into the right hepatic duct, and the left hepatic duct receives drainage from segment 1 to 4, and left hepatic duct is usually longer and the right one is shorter, and they both combine to form a common hepatic duct. There are a lot of variations in the biliary anatomy. We are not going to discuss them, but like most commonly they are more common on the right side. There are anomalous right posterior and anterior sectoral ducts, which can drain into the left side or into the directly into the common hepatic. And this main importance is they predispose patient to the biliary injury at the time of cholecystectomy. And the level at which the cystic duct joins the common hepatic duct is also variable. Sometimes it can be very low insertion, and this again can be a predisposing factor for a biliary injury at the time of the cholecystectomy. Now coming to the role of imaging in obstructive jaundice. The role of imaging is to identify and then the detailed assessment of the major bile duct obstruction. Normally, the ultrasound is the preferred initial imaging investigation and will be supplemented with a combination of CT, MRCP, that is magnetic resonance cholangiopulmonography, and in some centers, endoscopic ultrasound. So, what the questions that we need to answer are whether the bile duct obstruction is present or no. If yes, then what is the anatomical level of obstruction and what is the likely cause of obstruction? And if the cause appears to be malignant, then the staging of the malignancy. So the first task is to see if there is intra and or extrahepatic duct dilatation. They are the marker of duct obstruction. So indirect sign of obstruction is biliary tract dilatation, either intra and or extrahepatic. Normally, the intrahepatic ducts centrally should not measure no more than 2 to 3 mm, and more peripherally they are hardly seen. And even if seen, they should be clearly very smaller as compared to the adjacent portal venous branches. And the maximum diameter of the common bile duct is normally considered to be 7 or more is a predictor of bile duct obstruction in the jaundice patient. But this is only a rough guide. It depends on the age of the patient and whether the cholecystectomy is done or not. So in a post-cholecystectomy, up to 10 mm may be a normal. An older population, like up to the 7th, 8th decade, it may be 8 or 9 up, depending on the age. And if we are on the ultrasound, we are only able to see the upper envelope of the common bile duct, and it is not dilated. This does exclude the pathological dilatation of the more inferior portion. Because distal CBD is usually very difficult to see on ultrasound because of the bowel gas and all. So if the proximal CBD is seen and it is normal, then we exclude major pathological obstruction lower down. Now, depending on the anatomical level of obstruction, if there is hilar obstruction, there will be only intrahepatic duct dilatation, while distal CBD obstruction will result in extrahepatic dilatation first and followed by the intrahepatic dilatation. So, approximately 95% of the patient with bile duct obstruction will have biliary dilatation, and the degree of which is related to the duration and whether the obstruction is complete or incomplete. In 5%, there are clinical and biochemical indicators to suggest duct obstruction, but the ultrasound is showing no dilatation. In that case, MRCP is highly warranted because in few cases there may not be significant dilatation, but despite the obstruction being there. So most of these cases where the obstruction is there without significant dilatation are mainly related to small biliary stones, Primarysclerosing cholangitis, or postoperative stricture. Now, if the obstruction appears to be the malignant, then we have to assess the tumor resectability because that is important for the surgical planning. So, in malignant hilar obstruction, we should assess the proximal extent, whether it's going to the right and left ducts, any lobar atrophy, portal vein, and any extrahepatic or extrahepatic metastasis. In the malignant low obstruction, which is usually due to pancreatic carcinoma, the main factors are to look for the vascular involvement, lymph node mets, and the distal metastasis. So, which are the various modes of investigation available? The ultrasound, of course, is the first line modality. The other modalities available are CT scan, MRCP, ERCP, endoscopic ultrasound, and direct cholangiographies, which we are not going to talk about, and the hepatobiliary scintigraphy. So ultrasound is the initial imaging modality of choice because, as everyone knows, it is non-invasive, inexpensive, and readily available, and there is no ionizing radiation. And we are looking at the indirect evidence of bile by looking at the dilatation. So if CBD is 7 or more, it is considered to be dilated. And we can look at the underlying cause like a gallstone in the or CBDs too. or a mass in the CBD or head of pancreas. And usually only preparation required is to be fasting, preferably 6 to 8 hours. And like new generation ultrasounds are quite compact, so portable USG is possible. And another important application is color Doppler imaging, when we can assess the patency and the volume of blood flow in the critical vessels like portal vein, superior mesenteric and hepatic arteries and veins. Major limitation is it's highly dependent on the body habitus of the patient. So in the obese patients and those with a lot of bowel gas, it's very difficult to scan optimally, and it's highly operator dependent. So most of the times distal CBD visualization is very difficult on ultrasound because of the bowel gas. Now the next is IRCP after ionization of the contrast allowed the acquisition of images using the arterial, portal and delayed phases like triple phase post-contrast CT. And this can be reckoned into a three-dimensional coronal images to trace the dilated ducts up to the level of obstruction. And CT is now widely accepted the imaging method of choice to detect, stage, and assess resectability of pancreatic tumors. And also as a complementary to ultrasound for the evaluation of complications of gallstones like cholecystitis, pancreatitis, and for staging of other malignant tumors. The major limitations are there is ionizing radiation involved, and we need to give intravenous contrast, which can lead to allergy, and those are nephrotoxic. So in patients with renal failure, CT contrast CT is not possible. And also the contrast resolution is poor as compared to the MRI. And density of hepatobiliary calculi is very widely variable, unlike renal calculi, and most of them are not hyperdense. So it is very difficult to pick them. And sensitivity is so very low in detecting biliary calculi, and the role of CT for detection of hepatobiliary calculi is very limited. The next modality is the MRCP, that is now becoming the gold standard. So protocols normally used are the heavy T2 images are used, in which the bile will appear as a bright, and on the background we can see the stones. Patient is advised to fast for 4 hours, and usually it's optional, but normally it is preferable to give the oral contrast to lower the signal intensity of intralaminar fluid in bowel and like reduce artifacts of the bowel. So where different like superparamagnetic iron oxide particles, gadolinium, meglumine compounds, or simple pineapple juice may be administered as oral contrast. This is a MIP image from the MRCP subsection. So we can see the very nice, beautiful pictures of gallbladder, cystic duct, right and left hepatic ducts, common hepatic duct, common bile duct, and the main pancreatic duct. So advantages of MRCP are it is a simple procedure, non-invasive. There is no need for IV contrast always. Contrast resolution is very excellent, and sensitivity is very high in detecting hepatobiliary calculi. And can be combined with routine MR images to look for the liver, pancreas, extraductal disease, and other complications. So now the contrast MR abdomen combined with MRCP is now becoming the modality of choice for evaluation of biliary tumors in most of the centers. The major limitations and pitfalls of MRCP, as with all MR procedures, it's absolutely contraindicated in patients with cardiac pacemaker and cochlear implants. And another challenge is the normal vascular structures may cause focal errors of signal void. And it is very difficult to differentiate between a signal void and a stone on MIP images. It requires breath hold techniques for good quality images, and so in a critically ill patients, it will be difficult to acquire good quality MRCP images. And image quality is dependent on the magnet strength. 3 Tesla images will have much better signal to noise ratio as compared to 1.5 Tesla. And if we compare with the ERCP, the main limitation is we cannot perform therapeutic interventions like we can do in ERCP. And the spatial resolution is relatively poor if you compare with the ERCP, but that is slowly being overcome with the advance in the technology. So now we come to the different common conditions which present with the obstructive jaundice, and what is the role of imaging in each, and what are the common findings we see in those. So most common benign cause of obstructive jaundice is cholangitis. And 90% of the bile duct stones are stones that have passed from the gallbladder. They are also called secondary stones. So primary stones are those that arise in the bile duct, and these are usually pigment stones. And the common conditions which put them like hemolytic anemias are the conditions where there is a high risk for the primary stones. And for patients younger than 60 years undergoing cholecystectomy, 8 to 15% will have bile duct stones, while the figure will increase substantially in older patients. So ultrasound is the most commonly used initial imaging modality. Sensitivity is variable 50 to 80 depending on the technical factors like the patient body habitus and the bowel preparation. And positive stone diagnosis depends on the demonstration of an echogenic focus on both longitudinal and transverse planes, often associated with posterior acoustic shadowing. And another indirect sign will be to measure the bile duct diameter, because most of the stones are obstructing and they will cause a proximal dilatation. So if the bile duct diameter is less than 4 mm in patients which are undergoing cholecystectomy, the likelihood of distal CVD stone is very, very low. And as the diameter increases, the likelihood of duct stones also increases. And in about 20 to 30% cases, dilatation and the posterior acoustic shadowing may be absent, and only sign may be the echogenic focus in the bile duct. So diameter, as I mentioned, diameter of less than 4 carries a very high negative predictive value for cholangitis, regardless of the presence of the gallstone. So in all patients with suspected gallstone disease, it's very important to report the bile duct diameter report. So this is ultrasound image showing a echogenic focus with the proximal dilatation and the posterior acoustic shadowing, like you can see a dark band and a wide focus there. So this is a gallstone in a dilated bile duct. Then again another case, the proximal common bile duct is dilated, and there are multiple calculi in the distal CVD seen with marked posterior shadowing. So coming to the role of CT in hepatobiliary calculus disease. The bile duct calculi, depending on the composition, may appear calcified, they may have soft tissue attenuation, or may have iso or hypodense with respect to the surrounding bile. So we should use plain CT for the detection, and oral contrast should be withheld. We should give oral water to opacify the distend the bowel. High attenuation calculi can be easily picked up because they are surrounded by low attenuation bile. But the main challenge is to look for the soft tissue density or low density calculi. If there is hyperdense calculus, even impacted when there is no surrounding bile can be detected, because it is, if we see the hyperdense focus is in the course of the CVD, it is suggestive of a bile duct stone. But approximately 50% are of faint attenuation and almost similar to the surrounding bile or to the surrounding soft tissue structures. So this sometimes may be easy to pick by looking for a rim or crescent of bile that outlines this intraluminal densities. But it's very difficult to pick on CT, and with the advent of MRCP, the role of CT is becoming now very limited. Another indirect sign is abrupt termination of dilated CBD without any direct evidence of calculus. But this is more commonly seen in malignant pathologies and very less commonly in the stone disease. So these are different CT pictures which show the variable attenuation of the distal CBD. This is quite a hyperdense distal CBD calculus. This is almost equal to the density of surrounding soft tissue structures. This is quite hyperdense, and there is also the gallstones and the changes of acute cholecystitis. And this is calculus in the distal CVD. So the plain CT is better to pick the CVD stones. As you see on the post contrast, it is difficult to pick the contrast. With you can see here the plain CT much more better shows the hyperdense calculus. Also, there is a small cholangitic abscess in this patient, secondary to cholangitis. And this is a rim of bile, what crescent of bile surrounding the intraluminal calculus, which can help to pick up these subtle stones. So MRCP is comparable to ERCP for the detection of cholelithiasis and superior to ultrasound and CT scan. Stones as small as 2 millimeter are detectable, and they are usually seen as a hypo intense focus, like a voided signal, like they will appear black, surrounded by a high signal intensity bile, which appears white. So these are different pictures showing MRCP. These are multiple goldstones. You can see the black foci, and there is a sludge with a fluid level. Another patient with there is a multiple gallstones. Also, there is a multiple calculi, small calculi in the distal bile duct with mild proximal dilatation. This is a MIP image showing a distal CBD calculation with proximal dilatation. There are multiple CBD calculi as well as grossly distended cystic duct with stone in the cystic duct also. So this is another patient coronal images showing gallstones. Which is small stone in the distal CBD. This is a coronal image. This is an axial image. You can see a black focus surrounded by white bile. Another patient with the same gallstone and distal CBD stone. This is a MIP image. But in this patient, we can see that dilatation of the biliary tract is not that much. So some of these small stones may not cause much dilatation, and they may be missed on ultrasound. This is another patient where we can see the distal CBD stone, but associated with there is dilatation of the main pancreatic duct. And if you look here, there's hardly any pancreatic parenchyma visible. So this is like a patient is a chronic calcified pancreatitis. Along with that, there is a distal CBD stone. And this is a CBD calculi at multiple different levels. You can see all as a hypo, like black filling defects in the white bile. So this is like a cine image of MRCP, how we look at and how it looks like. So we can nicely see the gallbladder draining into the cystic duct, which is also dilated, the common bile duct. And then there is a stone at the distal end of the CBD. So now we come to the Malaysia Syndrome. It's a rare complication of gallstone disease that is caused by an impacted stone in the gallbladder neck or the cystic duct and causes extrinsic compression and obstruction of the common hepatic or duct, normally at the junction of the cystic duct and common hepatic duct. Two types are there. Type 1 is the common, where the obstruction is simply due to the extrinsic compression, while the type 2 is actually there is erosion of the common hepatic duct and there is a fistula between the gallbladder and the common hepatic duct, which is usually rare. So this is a case of Malaysia Syndrome. There is impacted gallstone in the cystic duct with a lot of inflammation around, which is causing compression on the common hepatic duct with dilated common and right and left hepatic ducts. And the common bile duct appears normal. Another case, the same findings. Cystic duct stone, dilated common hepatic and right and left hepatic ducts, while the common bile duct is normal. So coming to the benign biliary strictures, they are normally like most common are the post-operative and the post-inflammatory. So post-operative are most often a sequelae of either direct injury or ischemic injury to the bile ducts during biliary tract surgery. And in patients suspected of post-operative CBD structures, ultrasound should be carried out as a screening procedure. And if you see proximal dilatation of CBD with smooth tapering stenosis, then no further investigation is required. It usually suggests your post-operative benign biliary stricture. And if ultrasound findings are equivocal or normal, despite strong clinical suspicion of this CBD stricture, then MRCP, and in some cases if required, ERCP should be performed. Post-inflammatory strictures can be caused by cholangitis, chronic pancreatitis, most commonly due to the passage of gallstones, and penetrating or perforating duodenal ulcer. So in chronic pancreatitis, normally strictures are very common, and the most frequent pattern is like a long, 3 to 5 centimeter long, smooth, concentric, often tapered narrowing of the intrapancreatic portion of the CBD. While the strictures which are associated with the gallstones are normally very short, they may be single or multiple and can occur at any level. Ultrasound MRCP will reveal the dilatation of the biliary tract, and often you can see the underlying cause like gallstones or chronic pancreatitis. So in this, there is a lower end CBD calculi and there is a benign stricture. Now we compare the benign and malignant stricture. Normally the benign stricture, there will be smooth margins and it will be usually like a gradual tapering, not the abrupt cutoff. And there will be no associated mass or any enhancement. And if the bile duct wall thickening, if there, it will be like minimal, not like a gross abnormal wall thickening or mass, which are commonly seen in a malignant stricture. This is another patient with chronic pancreatitis, and there is dilated CBD, secondary to the distal CBD stricture. You can see the dilated MPD with multiple calculi. So now coming to one special condition, primary sclerosing cholangitis, which is a chronic progressive cholestatic disease of unknown etiology. Commonly occurs in males, and the median age of onset is 40 years. Luckily, it is not very common condition, but radiology plays a crucial role in the diagnosis, as clinical features are often non-specific. There is no specific serological markers, and histology alone is not diagnostic. So in primary sclerosing cholangitis, ultrasound has got very limited role, and the cholangiography, like normally now MRCP is the first choice, and if required, ERCP is the most definitive imaging modality for the diagnosis of primary. The most common pattern is there are diffuse multifocal short strictures in both intra as well as extrahepatic bile ducts. They are the hallmark of PSC. The strictures alternate with the normal or mildly dilated intervening duct, resulting classically in a beaded duct appearance. Sometimes the peripheral bile ducts may be obliterated by the fibrosis, can result in a prune tree appearance. And if we do the cross-sectional imaging like ultrasound or CT scan, normally there will be dilatation of the bile ducts, often associated with the thickening of the wall and contrast enhancement. The most important complications are the primary biliary cirrhosis and the cholangiocarcinoma. So cholangiocarcinoma occurs in about 10% of the affected patients and very difficult to diagnose early. It should be suspected if there is a progressive duct dilatation, like a long segment of dilatation proximal to a stricture, or if a solid enhancing nodule more than 1 centimeter in diameter is identified on a contrast MR or contrast CT. Upper abdominal lymphadenopathy is frequently seen in patients and alone should not be necessarily indicate development of cholangiocarcinoma. Another complication is primary biliary cirrhosis, which like normal cirrhosis, all the features will be there. But in biliary cirrhosis, the more common is to have the atrophy of the left lobe with significant coordinate lobe hypertrophy. So these are this MR images, MRCP images of primary biliary. This is early stage. You can see the beaded appearance with strictures, then intervening dilated segments mildly. So, and there is a one high-grade stricture of the left hepatic duct. There is another patient with more advanced disease. There are multiple areas of strictures and one dominant stricture in the left hepatic duct. This is a cholangiography picture showing same findings like multiple strictures and intermittent dilatation. This intraoperative cholangiogram taken during another finding which is showing a diverticular like outpouching from the common bile duct, which is a common finding of cholangiography in primary biliary, primary sclerosing cholangitis. This is the ultrasound picture. Normally you will see this bile duct wall thickening and dilated bile ducts, but role of ultrasound is quite limited. So coming to the next condition is a developmental malformation that is choledochal cyst. It's an uncommon congenital cystic dilatation of the bile duct, mostly present in the childhood. And the classical triad of jaundice, right upper quadrant pain, and palpable subpustule mass is diagnostic but very rarely seen. So complications which are associated with choledochal cyst are secondary calculi formation, recurrent ascending cholangitis with or without intrahepatic abscess formation, biliary pancreatitis, biliary cirrhosis, and malignant transformation into cholangiocarcinoma. So they are classified into 5 types according to Todani's classification. The type 1 is the fusiform cystic dilatation. Type 2 is a true diverticulum. 3 is like a focal secular dilatation of the distal CBD. Type 4 is like multiple cyst intra-extrahepatic, and the type 5 is the Caroli's disease, where only intrahepatic biliary radicals are involved and there are multiple cystic secular dilatations of the intrahepatic. Ultrasound is the preferred modality. You will see an anechoic cystic structure which is separate from the gallbladder and communicating with the hepatic ducts. And when needed, can be complemented with CT, MRCP to look for to confirm the diagnosis and to look for any complications. So this is the Todani classification. This is the type 1. This is a true diverticulum. Type 2. This focal is type 3. Type 4 will have multiple, and type 5 is isolated intrahepatic biliary radical involvement. So this is ultrasound image of choledochal cyst, a large anechoic cystic structure in the base of CBD. This is a type 1. This is multiple intra-extrahepatic biliary cyst, this type 4 choledochal cyst. Another patient with type 1 choledochal cyst, you can see a large, clear anechoic structure. And this is the portal vein which is filled with the flow on color Doppler image. This is another ultrasound image. And corresponding coronal CT, you can see the full CBD is dilated. That's type 1 choledochal cyst. And this is a portal vein. This is a Caroli's disease, type 5 disease, in which there will be multiple cystic secular dilatations isolated to the intrahepatic biliary radicals, and the extrahepatic biliary system is normal, usually normal. So now coming to the parasitic disease, which can cause the most common are the ascaris. They are like in a bowel, they can be seen as a tubular non-centering shuddering echogenic structures in the dilated biliary ducts, and when they are alive, they can be actively motile. So this is the image showing a worm in the CBD. Luckily, they are not very commonly seen in this part. Another parasitic infection, which is of clinical significance, is Chlororchis sinensis. And this is also known as recurrent pyogenic cholangitis or oriental cholangiohepatitis because it's more common in oriental countries. And adult form will be residing in the intrahepatic bile ducts, where it will cause obstruction and lead to a strong inflammatory response, leading to recurrent episodes of pyogenic cholangitis in late stages, periductal fibrosis and cirrhosis. Complications include development of intraductal calculi formation, there will be intrahepatic calculi, cholangiohepatitis, liver abscess, portal vein thrombosis, and it is also a predisposing factor for cholangiocarcinoma. Typically, there will be dilatation of the biliary tree, and there will be disproportionate dilatation of the extra and central intrahepatic, while very little dilatation of the more peripheral bile ducts. Also, we can see the prominent periportal echogenicity, and intrahepatic calculi are very common, seen in up to 90% of the patients. But the echogenicity is variable, like they may be hyperdense or they may look like a debris. Another common finding in recurrent pyogenic is pneumobilia, which is usually due to the stone of passage through the ampulla into the bowel, but sometimes it can occasionally develop due to cholangitis, which is caused by gas forming, but most of the pneumobilia is normally due to the passage of the stone before. And hepatic parenchymal atrophy is quite common, and most commonly involved segments are the left lateral segments and the posterior segments of the right lobe. So on MRCP, you will see the intrahepatic duct calculi very nicely. You can see the central intrahepatic and extrahepatic duct dilatation, and frequently there is decreased arborization and abrupt tapering of the peripheral ducts, which is popularly known as arrowhead sign. So normally the duct strictures are very short, less than 1 centimeter, very well seen on MRCP, but difficult to pick on ultrasound or CT. And atrophic hepatic segments will have a variable signal, often with crowded and dilated ducts. So this is a case of recurrent pyogenic hepatitis where the left lobe is involved. You can see multiple intrahepatic calculi, same on CT, with some lobar atrophy. Another case where there is a distal CBD stone as well as multiple stones in the right hepatic ducts. with dilatation of the right and left hepatic ducts. Multiple calculi in the left hepatic duct, which is grossly dilated, and there is also a CBD stent in place because of the previous CBD calculus. This again multiple calculi in the CBD with dilated biliary tract and multiple calculi in the dilated left hepatic ducts. So these are the cases of recurrent pathogenic cholangitis. Now coming to the malignant conditions, the most like cholangiocarcinoma is a malignant epithelial tumor arising from the biliary tree, and this excludes the gallbladder or the ampulla of the venter. And it is the second most common primary epithelial malignancy after hepatocellular carcinoma. Usually they have a poor prognosis and high morbidity. So considering the imaging features, they are anatomically they are classified as either intrahepatic, they are like a 10%. Most common is the perihilar or popularly known as Klatskin tumors, and the extrahepatic cholangioma, that is distal to cystic duct insertion. Morphologically, they are divided into three types. Either they can be mass forming, normally this is the intrahepatic variety, periductal infiltrating, that normally is seen with the perihilar, and the intraductal tumors are very, very rare. So normally patients with the perihilar or extrahepatic will present early with a painless jaundice, while the intrahepatic cholangiocarcinoma will remain asymptomatic and will be picked up as a liver mass. So ultrasound is the initial evaluation modality of choice, and then it's needed to be supplemented with MRI and MRCP normally, and CT for staging. Cholangiography like ERCP has main role for the palliation purposes, like to put the stent and to relieve the obstruction. So ultrasound we will in the most like in the intrahepatic cholangiocarcinoma, the ultrasound will reveal a liver mass, all usually intermediate hypoechoic appearance. It's a well delineated but usually irregular outline. And the most important finding is to look for the capsular retraction, which if present is highly suggestive of cholangiocarcinoma rather than other hepatic tumors. So on CT there will be usually hypodense and demonstrate heterogeneous peripheral enhancement, and on delayed images there will be gradual centripetal enhancement. Again, to look for the capsular retraction is the most important, and usually the distal to the mass, the bile ducts will be dilated. So MR has now become the imaging modality of choice, and we can see all the tumor mass, the bile ducts and the blood vessels, and they are all essential for determining the surgical resectability. Appearances on MR are similar to CT, but it is more sensitive and can assess the bile ducts more better. On now, the recent literature suggests that on diffusion weighted images, peripheral hyperintense target appearance on diffusion weighted favors cholangiocarcinoma over hepatocellular carcinoma. So this is a MR image. On T2 MR, there is a heterogeneous signal intensity hyperintense mass. The most important thing to look for is the capsular retraction, which is highly suggestive of cholangiocarcinoma rather than other hepatic tumors. And on contrast images, you can see initially there is a peripheral enhancement, and gradually it is feeding up centrally. And on delayed images, it will show a quite a significant enhancement as compared to the rest of the perihilar cholangiocarcinoma, also known as Klatskin tumors, are usually the periductal infiltrating type and normally arise at the primary confluence or in the proximal common hepatic duct, which is proximal to cystic duct. And these are very difficult to pick. Sonographic findings, usually the only thing we see is the intrahepatic dilated ducts, with or without isolation of right and left sided ducts, and lobar atrophy. Definite mass is rarely seen, and only if we see the intrahepatic isolated bile duct dilatation without evidence of extrahepatic dilatation, then this should raise the suspicion for perihilar cholangiocarcinoma and warrant MRI with MRCP. On CT and MR, they will appear normally as areas of bile duct wall thickening or thickening of the periductal tissue with altered caliber of the involved duct. Normally, the duct involved is narrowed, and they are most common at the hepatic hilum. The strictures associated tend to be longer, more than 2 centimeters, and there will be a lot of enhancement around, particularly on the delayed images, and there will be proximal dilatation of the intrahepatic biliary tree. Lobar hepatic atrophy is commonly seen in patients, and this finding coupled with biliary dilatation is strongly suggestive of cholangiocarcinoma. Atrophy is usually due to long-standing biliary obstruction, but may be due to the portal venous involvement, and usually there will be crowded dilated bile ducts in the atrophic hepatic segment, most commonly in the left lobe. So this is an enhancing tumor in the hepatic hilum, which is a classical tumor in contrast. So they are graded according to bismuth classification for surgical planning, and but for the prognostic staging, TNM staging is the one which is used. So this is bismuth showing how they are graded. Like they are isolated in one of the common hepatic, or they are extending into the right and left hepatic, or into the secondary ducts. This is another case of where you can see the intrahepatic biliary dilatation and enhancing mass at the hilum. On ultrasound, echogenic mass is seen, and that is dilated intrahepatic, while the extrahepatic, like common bile duct, is normal in caliber. So extrahepatic cholangiocarcinomas are usually small, and they have better prognosis than clad skin. An ultrasound will demonstrate biliary dilatation, and there will be abrupt cutoff at distal end. And the bile duct at the level of obstruction will be narrowed, or it will be widened if there is an obstructing intraliminar mass. Similarly, on CT, there will be dilated CBD with abrupt cutoff, and at the level of mass, there may be diffuse enhancing wall thickening, or if the mass is seen, it will normally be hypodense and will subdulate enhancement. Intraductal are very rare, and we are not going to talk about them. So this is a case of extrahepatic cholangiocarcinoma, in distal CBD, where you can see the dilated intrahepatic biliary radicals and dilated CBD at the proximal level, and at the distal end there is an enhancing mass which is obscuring the CBD, obstructing the CBD and causing proximal dilatation. Now, second is a carcinoma head of the pancreas, which is the commonest tumor to present with the obstructive jaundice. The most commonest tumor is adenocarcinoma of ductal origin, usually seen in the middle-aged and elderly, and it is twice as common in males. So normally the carcinoma head of the pancreas presents with the painless jaundice, while the body and tail tumors usually present with pain and weight loss. So typically it is a solid serous tumor which is a decreased vascular perfusion as compared to the normal pancreatic tissue, and this reflects in the imaging features. And most of the carcinomas, by the time they are detected, they are large enough to alter the contours of the gland. So they have a strong tendency to constrict or obstruct the ducts that lie within their paths. And then so often the main pancreatic duct and the common bile duct are dilated, leading to classical double duct sign. Metastatic lymphadenopathy also can contribute to the ductal obstruction. And the main thing is to assess the surrounding vascular structures like the portal vein, splenic and superior mesenteric vein, and arteries. And the duodenum is the most commonly invaded locally by the carcinoma head of the pancreas. So ultrasonography, they are usually hypoechoic as compared to the normal, and if they are necrotic, they will have heterogeneous echotexture. Color Doppler has a very important role to assess the vascular structure. CT is now considered to be the imaging modality of choice for the detection and pre-surgical staging of the pancreatic cancers. Typically, they appear as a poorly defined hypodense mass, and the normal pancreas enhances to a greater degree than, so on post-contrast images, they will appear hypoenhancing as compared to the normal pancreas. Like arterial phase imaging is the ideal one to look for the normal, the contrast between the normal enhancing pancreas and the CA pancreas. Like USG double duct sign may be seen, which is a dilatation of both pancreatic duct and common bile duct. Calcifications are very rare, and if they are there, usually they are due to the pre-existing conditions such as chronic pancreatitis. CT has a very high positive predictive value of 90 to 100% in predicting unresectability, and most important factor to look for is the relationship of the tumor to the surrounding vessels like superior mesenteric artery and celiac axis. If the tumor surrounds the vessel by more than 180 degree, then it is deemed as T4 and it is surgically unresectable. And also you have to look for a local invasion of the duodenum. So on MR signal characteristics, T1 images are the most important, where they appear hypo as compared to the normal, and will show slower enhancement rather than the normal. So dynamic injection with PET saturation and arterial phase imaging is ideal to detect these tumors. T2 is variable and not much of help. And on MRCP, you can see that double duct sign. So this is a carcinoma head of pancreas appearing hypoechoic with dilatation of the CBD. Another case where we can nicely see the double duct sign, dilated CBD as well as MPD, and enhancing mass in the head of pancreas. This another case is ultrasound showing hypoechoic mass with dilated CBD. Same confirmed, and here there is a local invasion of the second part of duodenum. More case where there is a dilated CBD, dilated MPD, double duct, and there is a big hypoechoic mass in the head of the pancreas. And CT confirming the same findings, double duct sign and enhancing hypodense mass in the head of pancreas. So periampullary carcinoma is the term which is used to describe tumors that arise from or within the 2 centimeter ampulla and include pancreatic head tumors, lower CBD tumors, ampullary tumors, as well as periampullary duodenal carcinomas. And they are very difficult to differentiate one from others, so they are generally reported as periampullary. And normally on imaging, you will see dilatation up to the level of ampulla, with or without dilatation of the pancreatic duct. So this is a periampullary carcinoma with a double duct sign. Enhancing mass in the region of ampulla. Another case, periampullary carcinoma, you can see enhancing mass in the distal CBD in the region of the ampulla with proximal dilatation. So ERCP, we are not going to talk much about, but it was regarded as the gold standard for imaging the biliary system before the advent of MRCP. And the advantage is that you can have the therapeutic intervention at the same time. So now it's the ERCP now is the intervention of choice in patients with CBD stones and palliation of malignant biliary obstruction. But the drawbacks are like it's high equipment cost and you need a skilled interventional endoscopist to perform there. And it's like a common complications are acute pancreatitis and cholangitis being an invasive procedure. So now with the advances in the MRCP, ERCP is evolving into a predominantly therapeutic procedure rather than a diagnostic procedure. Endoscopic ultrasound is a high-end modality. Now finally take-home points are like imaging has a major role to play in the evaluation of the obstructive jaundice, with ultrasound being the first line of investigation. And MRCP combined with contrast MR when needed is the gold standard modality with very high sensitivity and specificity for most of the biliary pathologies. And the most common benign cause of the obstructive jaundice is hepatobiliary calculus disease, where ultrasound is with the MRCP is the modality of choice, and with CT has got a very limited role, while the contrast enhanced CT has a very important role in assessment and staging of malignant lesions, especially the pancreatic head carcinoma, which is the most malignant cause of the obstructive jaundice. Some of the references which I have used. Thank you.
Thank you, Dr. Raj Kumar. Yeah, sir is showing video also. Okay, fine.
No, this is just an image of from MRCP showing a 3-dimensional view. Thank you.
Thank you, Dr. Raj Kumar, for the wonderful presentation. The topic is now open for discussion. We have our radiologist, Ashik sir, Dr. Biju, and our gastroenterologist, Dr. Bilal sir. So please add few points to the discussion. Thank you. Ashik sir.
Yes, ma'am. Hi. Dr. Ashik.
Yeah, yes,
Raj,
good morning, sir.
Good morning.
Good morning.
Good morning, Dr. Raj. Great talk. Very nice. To the point and very clear images. Very interesting cases as well. Congratulations on the talk. One thing I noticed after coming to UAE was the incidence of the oriental cholangiohepatitis, which is not very common in India. That is something which I noticed after coming in, especially in people from Bangladesh. They seem to be having that quite commonly. That was something interesting. And we had a few cases where our previous surgeon used to resect part of the liver, like left hepatectomy, right, to treat those cases. That's something interesting. Good images of those cases as well. Very, very nice presentation as usual.
Hello.
Thank you.
Hello.
Thank you, Ashik sir.
Hello. Hello.
Yes.
Yeah. Yes, thank you, Dr. Raj Kumar, for the excellent
Yes.
presentation. Yeah, you have discussed in detail about all the modalities available with us and their role in most of the diseases we frequently see, like CBD stones, um, or RPC, recurrent pyogenic cholangitis, or we could call it OCH, and then malignancies also. So, how to utilize this investigation? So, if you have a patient who has a presentation, who presented with the pain, gallstones, and the dilated CBD on ultrasound with the stone in the mid CBD, we directly go for ERCP. This is how you utilize it with a therapeutic intent. No need to do MRCP in such situations. Yeah. If we have a like doubt in the diagnosis, then we should always first go for MRCP. Like this, we have a gallstones, we have a pain, but we don't have a dilated duct, but the bilirubin is elevated and ALP is elevated. Under such conditions, we should always go for MRCP first. So there will be some stone without dilatation, and then which will not be utilized. Ultrasound is not good for lower end of the CBD, as you rightly said. Upper end proximal stones it can pick, but distal and lower end stones will usually miss up to 60-70% of time. Then ERCP is always for therapeutic. It has no role in the diagnosis now. Since the advent of MRCP, ERCP is only for therapeutic role for removing stones. And as you said, rest you said everything in detail about the once you have proximal lesions, we have intrahepatic biliary ducts, you should always go for MRI. Once we have a CT scan, malignancies, we should have both CT scan and MRCP. That's all.
Thank you,
Yeah,
Bilal sir.
Dr. Ashik said, yeah, we don't see many RPCs, or you can call it oriental cholangitis. But in our part, in Kashmir, we have a lot of ERC, this RPC. It is usually seen in the Far East, like Vietnam, Taiwan, where we have a lot of these zoonotic sinuses. But in our part, it is the ascariasis. Even we have removed many times fasciola hepatica live from the CBD by ERCP. We thought it was a stone. We did ERCP and there was a fasciola hepatica and multiple fasciola hepatica living in the biliary tree nicely.
Great, sir. Great to know that, sir. Thanks for the info on that.
Any
Thank you, sir.
questions from the audience?
Actually, there's one more modality which we're not doing in the UAE. It's called IV cholangiogram, actually, CT cholangiogram, IV CT cholangiogram, where they give a particular dye known as bilescopin, which is a IV biliary agent, which after about 2 to 3 hours will be excreted by the biliary tree. So then you can actually see the biliary tree as white instead of seeing it as black on the CT. It was specifically used for bile duct injuries post-surgery to see if there's any biliary leak or not. In that case, they were using this. But unfortunately, that is not available in UAE, that particular injection, IV injection. So they're not doing that. So in our case, on MRCP and then follow-up MRCP after 2 to 3 days will show better if there is a bile leak or not in surgical cases. That is something which we have, that's like department protocol we have formulated actually over the last few years to make sure if there's any biliary injury or not.
There are some other investigations which are not the part of radiology, like cholangioscopy, POCS. We do obstructive jaundice. We do POCS or cholangioscopy or spy camera. We go there, we put a camera into the CBD. We can take the brushings. If the stricture, we can take the brushings. We can take biopsy, and we can do the even dilatation of the strictures. And then another like nuclear medicine imaging. You have not mentioned about because that's not part of a radiology imaging, like PIDA scan. These are also used for the obstructive jaundice.
Thank you, sir. Any questions from the audience? Or any points to add? So if no more questions, we can conclude this session. So thank you all for actively participating in the discussion. And thank you, Dr. Raj Kumar, once again for a wonderful presentation.
Thank
So
you,
see you
madam.
all for the next Sunday CME. The post-test as well as evaluation is there in the chat box and AHS WhatsApp group. Please fill up them before concluding the session. So thank you.
Thank you.